I am Dr. Ajit Mehta from Jahangir Hospital, Pune. So we have a very interesting case. Calcific coronary artery disease, Lettman bifurcation, and calcium modification technique under intravascular imaging. Is it? Okay, sorry. So, so he's a 59 years old gentleman, diabetic, hypertensive, has peripheral vascular disease, diabetic foot, has had debridement 2 or 3 times, has had crescendo angina for 15 days, was shifted to our center for further management. Echo showed anterior wall, regional wall motion abnormality, ejection fraction of 45%, and was taken up for the angiography. If you see the angiography, you can see there is a mild plaque at the distal left main. Proximal LAD had a significant disease. There was a disease at the osteoproximal part of the circumflex. In the cranial view, in the mid LAD, you can see there is a trifurcation disease with 2 large diagonal coming up there and some disease beyond the diagonal. And if you see this in LA caudal view, there's an acute bend in the proximal LAD. At the site of the lesion, there's a tight disease at the osteoproximal circumflex, and the right
Also,
coronary
how much?
artery
What is the
had
distribution
about
of
70% disease. Sorry for the right coronary artery had about 75%, 70-75% disease in the PD. So this was a dry run just to show the significant calcium at the proximal part of the LAD. Tram-track calcification, which signifies
before we do it, we go to
calcium in the
do
LAD.
a imaging, pre-procedural imaging, so that we can understand the calcium anatomy. How dense is the calcification? You can see it in this.
Septal.
And there is a trifurcation distally, so wire is trying to enter the septal.
Can you have the parallel image here?
No, you have crossed. So here we have crossed the. See, this is the. Yeah, we have crossed the LAD. LAD has also got disease, and we are going to do the OCT run after that. So this is we have crossed. Now we go to do the. Can you get the OCT, please?
I think we'll have to dilate it. Will OCT go?
I think so. Should go. Let's try it without it. If it doesn't go, we'll dilate it. We can.
Okay. OCT.
So we did.
So as we are doing it with OCT, we are trying to minimize the contrast usage. We are not giving much contrast for the wiring.
This is a large artery. You see the size of the circosteum. So here we want to minimize the burr use. So probably orbital will be better because it's a very large size artery, and the same burr we can use in both the vessels, both the branches of the bifurcation. So keeping that in mind and using one burr, probably orbital atherectomy will be the choice.
So if you are doing the atherectomy in left main to LAD, do you intend to go beyond the diagonal, or you like to keep it before the diagonal?
Before the diagonal. Here the vessel suddenly becomes very taper, and there is an angulated portion, and there is not much calcium there. The calcium is proximal.
Size discrepancy is also lost.
Size discrepancy, and calcium is located more in the proximal area. And then go ahead. And as we are aware, the calcium is better seen in OCT because as IVUS is concerned, you can't see below the calcium. The thickness of the calcium cannot be assessed. With the OCT, you can assess the thickness of calcium, the arc of the calcium, and there are points with this which is and there is length of the calcium.
Yeah.
So now we analyze the images.
So there was a significant, almost 360 arc of calcium. The depth of calcium was more than 0.5. The length was more than almost 15 to 20 millimeter. There was by all the criteria, the calcification was very significant, large size proximal LAD. we had option of doing orbital versus rotational or IVL, but then we thought, for a better luminal gain, doing orbital would be a better choice in this case. So we went ahead with orbital atherectomy.
Seen with quite
And,
significant calcium, you can see
Before doing that, we
on
thought we
either
will
side.
do,
Right, the arc is almost maybe 270.
The saline is it?
It's
Here the
interesting
lumen,
though,
you
'cause
can
it's
see the
mixed
calcium and the-
there in terms of its appearance. Akiko, what do you think of?
Sorry, please
So-
go ahead.
so-
Go ahead. I am muted the volume.
She was just saying there's one place where it looks like it may be circumferential, but it doesn't look that.
super calcified, but there is one place I see the circumferential calcium, what you mentioned.
Yes.
And other place is actually mixed plaque. It's not only the calcium, also the lipidic plaque.
Yeah, I mean, I think this is a good OCT where you have to be really cautious because you see how bright it is near the lumen. That's typically going to be lipidic. And then behind it, people assume, oh, this is calcified. But it actually, like, this is not, there are
Okay, so-
areas.
This is here. This is 360.
360.
So that is more characteristic than any of the other locations that we're seeing.
But it's relatively focal. It's not super long in terms of the 360. And also 360, when you go to the thinnest, I do think that's close to 0.5. So I do agree this is severe, but one choice is you can go like the regular balloon or cutting balloon can be fracture.
And this is actually one of the things where Ultron 2.0 is useful because because of the software, you won't necessarily make that same mistake as you make with your eyes when you think that it's extending throughout the whole vessel. So, okay, great.
So I think this is the pullback from the circumflex. We did pullback from the circumflex as well.
Yeah, circumflex ostium is actually more likely non-calcified plaque, right
Yes,
here.
It's more of a fibrotic.
Yes,
and a little
agree,
bit of.
yes.
So the initial plan was to do orbital in both LAD and circumflex, but then we changed the plan, just did orbital
There is
in
calcium
LAD,
there also.
thinking that there was no significant calcium.
At the
So
ostial of the
imaging-
circle.
Still of the
Perfect.
circle.
Imaging helped us. We could avoid
But
unnecessary.
there is calcium, which is a
Rotational
blob of
effect.
calcium which came just now. Yeah.
Very focal.
Doctor.
So basically, the orbital atherectomy,
So this is just to show everybody, because we have not been used to doing orbital in most of the centers. What exactly is orbital atherectomy? What are the system parts of the orbital atherectomy? We just want to highlight those things.
also, plus it also helps in advancing the birth. So we'll show you the atherectomy. Please, can you get the? So can you show the fluid? This is a special fluid which is used for this
Viper slide.
Viper slide fluid, which is attached to this pump, and this comes, it's a white viscous fluid, but it helps in the cooling of the atherectomy device. So diamond 360 diamond bar, and you can see diamond back 360. Now this has got basically divided into two parts. Can you show it here? Now this is the advancer. Now this advancer has got an on-off switch on the top. It also can lock it, and also you can move it forward and backwards. So it's got three functions. It's got an on-off switch. You can lock it, you can keep it horizontal or parallel to it, and you can advance it. Now coming back to the rear portion, it has got two things. One is the drip, which you can see a drop shown here. This is to increase the drip of the fluid if you want to, and it's got two speeds. One is 80 and one is 120. Most of the thing is done at 80 only, but sometimes if you have a very large vessel you can go to 120. It should not be done as far as possible in the vessel less than 3 millimeter. Larger the vessel, you can go higher speed. Now this, behind this is a clip which you can see is a brake. By pressing it down, you put the brake and
Advanced flex tip. Do you want to talk about the difference between the burr of the orbital and rotational? Do you want
Yes.
to say? So how does it differ?
So this basically, the most important thing in orbital atherectomy is you can go forward and you can bring it backwards. So you can do atherectomy in both the direction, as while moving forward and while coming backwards. So this is not available with any other atherectomy device. The second is one burr can be used for a smaller.
So basically, the important difference between rotational and orbital, basically it's a bidirectional differential sanding with orbital as opposed to unidirectional in rotational atherectomy. That is the main important difference. Second, we will come across
Vessel or a larger vessel. So you can use with one burr and you can do it. The other thing is there are certain conditions where this works wonder, that is if you have the osteal RCA disease. If you have osteal RCA disease, you can go forward and bring it back while cutting the osteal, and that prevents trauma to the osteum. Larger vessels, it is another very good option.
So now solution, we have to add 20 ml of that solution into 1000 ml of normal saline. Am I correct? Yes. Okay.
Pause.
And that is attached to
Just one thing to clarify with that is that for an osteal lesion, that makes sense if you're going to do it in reverse. But if it's very tight, you definitely do not want to use orbital atherectomy in a tight osteal lesion, because what happens is you're not coaxial and it orbits and you can dissect the aorta that way. So you have to have enough of a channel to be able to get it forward through with the glide assist to make it safe in an osteal lesion. So the only reason I want to interrupt is because I don't want anybody to take away from this that it's the device of choice for a tight osteal lesion, because it absolutely is not.
Right.
So
I mean,
do you mean to say we
in the
should do?
beginning, when the rotablation was new, osteal was not a lesion that you actually did rotablation.
Right.
So do you want to say if you have tight osteal disease, should we do balloon dilatation before take these devices?
Well,
Or
I mean, if it's
probably we should start doing ablation, from the.
I would use rota in that case. If it's a tight osteal lesion and you need to be able to get through, the balloon's not going to help you very much. So just use rota, especially for new users. You can get it coaxial, but even with rota of an osteal lesion, you can cut the wire, you can get the burr trapped. I mean, these are not the most straightforward things to do.
But then you're not worried about burr entrapment with rota.
I am.
If you jump into the osteal disease, tight osteal disease, then you jump into the lesions.
Yeah, I'm definitely always worried about burr entrapment, but burr entrapment in an osteal lesion is a much easier problem to fix than a dissection of the aorta. So that's the difference.
Okay, point one, take
Like I can fix the burr entrapment, I can't fix an aortic dissection. The surgeon has to.
Sensor, and once your fluid is gone less than 200, it automatically stops. The console automatically stops, because probably there is no enough lubrication going into the system. So this is also a very important indicator. And other important thing, when we are doing burring with orbital atherectomy, every 25 seconds it gives a beep, so giving an indicator that it's time for you to stop now.
Connect.
So the plan is to do orbital atherectomy probably.
So now this is the brake which you go to attach, and once the brake, we lock this with the brake. This is now we go to on the device, and you can see the fluid is coming out.
Yeah.
So when we take the Viper advanced wire, it is same as we do for rotational atherectomy, rota wire. Either we could do it with the glide assist, or we can do it two operator working simultaneously. So or probably this is how we can take the wire.
Ready to go in.
Do you want to go on a dyna assist or want to go?
We go push and pull. That is the best.
It's slightly
So should I go?
better
Yeah.
wire to track more than rota floppy wire.
So here we are taking the device in. You can see the wire.
I mean, it has to be a coordination between the two operators.
And Sanjog illustrated yesterday, you can do it single operator as well on glide assist, but you just have to have the wire come back as you advance it forward.
So it just
And one nice thing
Yeah, we
about
have already
glide
removed the
assist is
tension.
it's
So here the
5,000
most
RPM.
important.
Dynaglide is typically 30,000, so it's a really atraumatic way of getting into vessels, and you don't have a lot of tension stored or anything else like that. So it's a nice feature, and you can do it with the brake on or off, which is very nice. You don't have to defeat the brake, but because the wire is free, you have to make sure you're holding the wire so the wire doesn't move.
So this is a very important slide just to demonstrate how, what is the main difference between rota and orbital. In rota, we have a quick pecking motions. In rotational atherectomy, vis-a-vis in orbital, we do very slow, gentle movements of the bird so as to get a better luminal gain. So if you see the diagram here, if you are about 10 millimeter per second with 120 RPM, the luminal gain is much lower as compared to 1 millimeter per second with 120 or 80 K speed. So the luminal gain is better if you are very gentle and slow in advancing the bird.
Yeah, if you go slow, the biggest advantage also
Being
is
done.
that the bird trapment is less likely. You know, we are more worried about it than the lumen gain because you're going to change the compliance no matter what.
So here rest the hemodynamics are stable, and we'll again do the bury.
So, do you want to say what is the difference between rotational and orbital atherectomy as far as burying is concerned? I mean the speed,
Yeah,
the
here-
attitude, how do you go, how do you do the pecking movement in rotational
See,
versus?
rotational movement, the movements are fast, they are pecking, there are even what is known as cobra maneuvers have been described. But here it is a
to
slow and a gradual movement. That is the most important here. We are doing a gradual, slow advance. And another thing is, in doing this orbital atherectomy, we do not stop at the lesion. Once we have crossed it, we may come back, not stop the burr in the lesion itself. So he is gradually advancing it about less than 0.5 millimeter or 5 millimeter in a second.
The other thing,
Probably in the last frame you can see it jumped.
because there's no front cutting, there are people who feel that it can't cross tight lesions, but because it spins, it defeats those frictional forces and you can actually get through lesions that are tighter than you think. For uncrossable lesions, no, this is not the tool, you use rota for that. But for many tight lesions where you might not think it would work, with reasonable guide support, you can actually cross, which is a nice feature. And burr entrapment, it can happen, but it's much, much, much less frequent than with rota. If it does happen, you don't keep spinning, you have to stop. There's a timeouts feature in the thing, and you stop and then you can sort of bring it back.
So this is how orbital works. It modifies intimal as well as medial calcium, fractures medial calcium because it orbits around the vessel. In the vessel, there is a technique called differential sanding. It only ablates the hard calcific things in arteries more than healthy tissue that gets deflated. So this is what we call as a differential sanding. Pulsatile force has much more effect on a deeper as well as superficial calcium.
Yeah, my only caveat with that is you have to be careful with wire bias, and you have to be careful around bends because it's not entirely true that it won't affect normal tissue. So if you take an orbital atherectomy catheter in a completely normal vessel that has a bend on it, you're going to have a problem. So you just have to be, somewhat cognizant of the wire bias as you do it.
So extreme tortuosity, we should avoid doing
I would
orbital.
totally avoid it. Totally
Absolutely.
avoid it in extreme tortuosity. And the cracking of the medial calcium is not just the device by itself; it's the device plus an NC balloon after.
And your movement,
that does it.
they can tell you. At this point, the most important difference between doing orbital and rotational atherectomy?
काय होते विचार क्या अरे कोडला
So after that, we went ahead did balloon dilatation with 2.5
ये कर ले।
millimeter balloon.
ये इसके आगे।
Patient at this point of
Come
time
back,
had some chest discomfort, little
This is
drop in
hum.
blood pressure, not little cooperative.
This is
So we did not do imaging after the
wire
balloon
दो, give another
dilation.
wire.
We wanted to fix it. The LAD because there was slight slow flow in the LAD with symptomatic
थोड़ा slow flow.
patient
Diagonal
had
में slow flow हो गया
angina,
ना?
little drop in blood pressure.
बस we
So
are
we
good.
wanted to
So
keep it quick at this point of time.
कितना 23
अरुण it was
2.5 23
यहाँ से लेना पड़ेगा ना
तो फिर लंबा
प्रेशर कम हुआ है नहीं ना ठीक
वायर बैलून
This is 2.5 by 28 Zine Sierra. that we went beyond the diagonal. The whole idea was not to keep the overlapping segment across trifurcation. So we were just way before the trifurcation.
बस contrast then.
We should not
Can you just do a stent boost on?
आएगा LA
This is,
Say, Varun.
we went ahead, did Leftman to LED stent with 3.5, 38 Zine Sierra again, and overlapping the distal stent that was post-dilated with 3O balloon at 15 to 16 atmosphere. We did not do anything to the circ at this point of time. It was not much calcific, it was more of a fibrotic, but as patient was little unstable and not little cooperative, we had to go ahead and do provisional stenting without preparing the circ ostium. Circ ostium looks tight here. We knew we will be able to do good to the circ ostium. Went ahead, did proximal optimization with 4.5 into 6 millimeter balloon in left main.
This wire be there. Give me another wire. Bro. This wire be there. Give me another wire. This wire be there. Give me another wire. Bro.
Give a Versatan.
Yeah.
So what is the importance of this wire? We have a jailed wire. So this is very important in bifurcation so that it helps in crossing. We know the route where to cross, and it also helps in distal crossing, which we want in this, not a proximal crossing. And we have
Because we are
taken
going provisional, you're saying.
so we have taken a bend in this.
LA coordinate.
We can show in the picture that. So here we are taking another wire, the third wire. Normally you can use it, you can take out the LED wire and put it, or you can do a third wire. So here we are doing a third wire. Now LED wire, if you have to do, you have to bend the wire before you take, so you have the same type of a bend where you, the vessel diagram. So here you can see that we are going to cross into the, from the distal stud. So we'll go slightly into the LED, pull it back and then cross through the distal stud. So this is the most important step, crossing distally. Give me another talker, please.
Can we have a little zoom picture?
Here you can, yeah, it is in the distal. Just take a record. Yeah.
So we had crossed the strut distally
See,
here.
this is a distal strut crossing.
Circumflex. You can see wire as a marker there. Pull back the wire from the LED and then recrossed into the circumflex.
So we have crossed the distal strut, and now
2.5 plan now.
another, is it covering, is it jailing, or we are free of the, and then we do a deb with a, and use a kissing balloon, and then we'll repot it.
So the strategy here was
probably
send
require
left main to
4
LED and then DEB in the circ. The strategy is a drug-eluting balloon in the circ?
Yes. So we cross over, we pre-dilated circ ostium with 2.550 followed by about 3.512. Circ ostium on OCT pullback was about 3.5. So once we prepared the circ ostium lesion well, we thought we'll do provisional with hybrid approach, do DCB to circ. We got a good result on circ ostium. We wanted to keep a less metal as far as possible.
Yeah, no, makes
And then
sense.
provisional is the best strategy for such kind of lesions because we have got a good result. If had there been a dissection, probably we would have to change the strategy because it was a big circ. We didn't want to lose that.
Give me contrast, please.
So this is 3.512 of 15 balloon. So do you want to say any particular precautions we should take when we are thinking or probably contemplating doing DCB when we are doing side branch pre-dilatation? Anything particular thing what we want to do it?
Not really.
So should we always do with the cutting balloon if you are doing DCB, NC balloon?
No, I think if you're, if you're reasonably confident about the lesion characteristic, I don't think it is essential to either one. I think you are dictated more by your imaging on how the lesion is.
Because of the circ ostium was more likely fibrotic and the chunk of the plaque, I think the cutting balloon here
Would have
seems
been
to be
a
the good
better
idea.
choice. We thought as well as that, but I think we got a good result with 3.512 balloon. And the always a chance of if you have a land up with a significant dissection, then you end up with putting a stain. And then as far as DCB guidelines, even if you have about 30% less stenosis, So I think we should accept it. So, we keep that in
Especially
mind.
at this location, I think that, if it restenosis, then you can do what you were going to do the first time around. So for the patient, if this works as a strategy, that it's good. What we do need though is, larger scale, longer term data, because the ostium of the circ always restenoses, and so to see that there's an appreciable difference would be great.
So
But this
basically-
looks pretty good.
Yeah, so we always know, I mean, circ is a different animal, restenosis is much higher at circ. So we try to avoid, even if it's a large, sizable circ, we thought we might as well avoid putting a stent in circ and do a hybrid approach.
Yeah. Is it the distal LAD has some spasm or something going on down there too?
Good.
So we are going to do a DCB in the ostial circ, and we
still
will
haven't done
keep
the
a
DCB.
normal balloon at a lower pressure so that we don't have carinal shift while doing a DCB.
But,
So what size of
one misconception about DCB in general, though, is that people think of the DCB balloon as the balloon plus the drug effect, and really what you're trying to use the DCB for is simply drug delivery. So this type of origin, you're not going to get a better lumen with the DCB balloon. That's not the way to think about it. The way to think about it is we're just leaving the drug so that it hopefully doesn't restenose.
So what we try to do, what do you feel? Just do plain DCB to the side branch, or keep a kissing balloon and keep one balloon in the main branch as well when we are doing DCB to the side branch? Because the concept of carinal shift or the plaque shift will always be there if you are doing just simple side branch dilatation with DCB. So should we keep one balloon in main branch?
I don't think we know the right answer to that, but generally speaking, if you just dilate the side branch, you'll deform the main branch stent. So most would think of some sort of kiss or something like that. Akiko, you agree? You just had a long workshop on bifurcations, right? So
Should we sequential or should we do kissing, simultaneous kissing? That's it.
I would probably go with kissing.
Kissing.
Yeah.
The thing
that's what
is,
we did.
this
Because you're also worried about
is
not damaging the stent.
balloon which is folded, so therefore it prevents
drug loss?
drug loss. So this is a plain balloon which is a DCB here. So we are doing simultaneously just to prevent carinal shift when we do this. That is the aim. So I have got a DCB.
you have got a DCB?
What we
So
did,
I'm
we
going to
did
do a DCB.
simultaneous kissing balloon.
Now this is a prolonged
3.5
dilatation, so we
We got to be careful
with the pressures.
in LAD and 3.5, 15 prevail, that is Medtronic, backlit accelerating balloon in left main to circ. And we could, keep the inflation for about 30 to 40 seconds because with left main patient was struggling with hemodynamics, had angina, so we didn't want to keep it for 1 minute. And I think I need to finish it off.
yeah, we need to
quickly.
wrap up for the.
So
the
I think
one advantage of not
I-
doing the sequential, or not doing it simultaneous, is if you inflate from the left main into the circ, just the DCB, you'll still have flow down the LAD because of the sizing. And so you can probably keep it up for the full minute if needed. So that's just one
So
thing.
there is a small dissection this
Yes,
study, and this is hematoma, but I think it's borderline.
We realized that it was small dissection, but it was less than a quadrant and less than 1.5 millimeters, so we left it alone. So this is the ostium of the side branch, no struts across the side branch ostium. There was some malapposition in the, where there was a LED trifurcates. We went ahead, did post dilatation with 275 balloon at a higher pressure. There was some malapposition in the ostial, in the part of the left main. We went ahead and did, blew it further with 4.5 balloon at a very high 26 atmosphere. So that malapposition was also corrected.
But the
And-
origin of the circ looks great. Yeah, that looks great.
Thank you. So, because of lack of time, I'll just quickly go through.
Yeah, just show us the final because we have to wrap up. But a really, really nice case demonstration of, the imaging, the modification, and then
So
a hybrid
the
strategy.
final report, after doing imaging, we realized we had to go up a little bit on a higher pressure at the left main. And so this is the final result. I hope we have the picture.
That's great.
Good.
Very nice.
Very nice, yeah.
So the trials, Orbit 1, 2, Eclipse trial, 1 year target vessel failure revascularization is about 5.8 in Orbit 2. We are, this is all we know.